So hello everyone, I'm Dr. Chow Ying from Queen Mary Hospital, pediatrician, and today we come to our lesson about pediatric sedation, and this lesson will focus on the intra-sedation, the intra-procedure phase specifically. And I need to bring you back to this practice recommendation for procedural sedation in pediatric specialty outside operation room, which has been updated and will be effective in 2021 in May. I strongly encourage you to read up this practice recommendation because it contains all the useful information required for procedural sedation in pediatrics. But it only applies in general pediatrics population, but it does not apply to children receiving general anesthesia and monitored anesthesia care by anesthesiologists. Or any sedation in the PNICU. But it will also apply to other pediatric age group that in the surgical specialty, etc. So my lesson outline will be divided as follows. First, we'll talk about timeout and safety check, and then followed by facilities and monitoring, personnel and training, and then to the sedation method, administration of medications, and the detailed about each medication and how to choose among many of them. So I believe many of you must have heard about the Murphy's Law, that anything can go wrong will go wrong. So it also applies in sedation. So this timeout and safety check practice has been used in the 90s, started in Prince of Wales Hospital. This practice originates from surgery. So the main aim of this practice is to prevent wrong patient, wrong site, and wrong procedure. So it is should be performed immediately before the intended procedure, and we should confirm whether the patient is correct, and also need to verify the informed consent, and then confirm the correct procedure, the site and the site of the procedure. And there should be no intravenous sedation given without completion of the timeout procedure. And even if it is an oral sedation, it should be also done before with the timeout procedure done in the ward. So this is part of the checklist that available in the practice recommendation, that we need to perform a sign-in and also time-out procedure. Sign-in means by the procedure done before induction of sedation, while time-out should be done before the incision of the skin, so for surgery, but if for procedural sedation, it is for immediately before the procedure. So for the pre-procedure sign-out, it is recommended to do the following, like confirm patient's identity, obtain consent, confirm that there's a correct consent, also do a screening evaluation of the fitness for sedation, for example, to take a brief history, know the past health of the patient, any presence of allergy history, any history of difficulty in sedation, and perform a general physical examination. And also confirm the patient has adequate fasting time for the respective procedure. And to see if the patient needs any steroid cover, and also check the intravenous site, whether it is big enough, and also whether it is patent. So right before the procedure, timeout should also be performed. I need to confirm the patient's identity name, and also have the full explanation of the procedure, and also check again if there's any allergy or alert, and also check the sedation drug expiry date and dosage. So during this timeout procedure, a speak-up culture is encouraged. It is to promote a good teamwork. And also, no matter where the practitioners come from different specialties and also from a different rank, they should be willing to speak up and discuss with other team members whenever they see a safety concern. So the next part will be about facilities and monitoring. So first of all, the location for performing the sedation should be with adequate space, and also good lighting, and with a trained staff, and also the appropriate equipment. So I will go on to talk about the sedation equipment one by one. Before doing the sedation for those children, essential equipment must be in place regardless of the desired depth of sedation that is intended, because sedation is actually a spectrum. Initially, you aim for a minimal sedation, but it may progress to a very deep sedation that out of your expectation. So all the equipment and drugs must be checked before the procedure, and also it should be maintained on a scheduled basis. Different size of emergency and monitoring equipment for children of all ages and size should also be available. So this is a list of the equipment that suggested needed for sedation. First of all, oxygen supply and suction of the appropriate size of the suction catheter. There should be a defibrillator in close proximity and the appropriate size defibrillation pedals for children. And intravenous medication, and also the catheter and also airway management equipment, and emergency medications, stethoscopes, some monitoring device such as continuous pulse oximetry monitoring, blood pressure measuring device with the appropriate size cuff, ECG with the electrode of different size, and also may or may not with a means of monitoring for respiration or ventilation, either by visually counting the respiratory rate and assessing the respiratory effort, or by continuous end-tidal CO2 monitor, what we call a capnography. I will further elaborate on this one by one. There's also an acronym for remembering this sedation equipment called SOAP-ME. Start with suction, O for O2, A for airway, back mask, ventilation, intubation equipment, P for pharmacy, M for monitor, E for equipment for individual case, such as when you expect a potential difficult intubation, you may want to bring like a laryngeal mask and or endoscopy equipment that may require. So I'll talk about suction first. It is very important during sedation. It helps with clearing up the secretion, sputum, saliva. They may inhibit coughing, cause laryngospasm, breath holding, and oxygen desaturation. And also, if there's a vomitus or regurgitation of the gastric contents, the suctioning can prevent these vomitus from aspirating back into the airway, causing aspiration pneumonitis. So this is a picture showing that this is the wall vacuum with a pressure gauge, and this is a turn on and off button, and this is the tubing connected to Yanker suction over here, which is a more rigid type suction. This is the suction reservoir bottle. So different hospital may have different setting, but there should be a vacuum source and also a gauge that with pressure, negative pressure that you apply on the suction, and also with a collection bottle, tubings, suction catheter. No matter it's a soft kind of suction catheter, which with different sizes, and also need to be chosen if for appropriate size if the patient is endotracheally intubated, or it can be a rigid type of what we call a Yanker suction. And when the patient is being transported to a suction or the place that without a wall suction location, then a portable kind of suction should also be available. And the suction should be dedicated to the practitioner administering the sedation, and it should never be shared with the suction used for operating procedure. So, however, vigorous deep airway suctioning may cause bradycardia and causing laryngospasm, induce vomiting, and in turn causing aspiration pneumonitis. And also nasal suctioning can also cause epistaxis, especially in patients with bleeding tendency. So second is oxygen. So the oxygen supply can come from the wall oxygen outlet or from a transporting cylinder. This is the flow meter. And it can be delivered through different devices, from a nasal cannula to a simple face mask to a high concentration, oxygen concentration, and non-rebreather mask. So the oxygen delivery devices have a variable performance. Let's say for nasal prongs, it can only deliver around 0.5 to 4 liter per minute, which comes up to 24 to 40% of FiO2. So, however, for a simple face mask, it can bring up to around 50 to 60% of FiO2. However, the inspired FiO2 varies because it depends on few factors: the oxygen flow rate that you are providing, the mask size and fit, and also the patient's ventilation rate, inspiratory flow rate, etc. For a non-rebreather mask with a reservoir bag, it can deliver a higher oxygen FiO2. It can be up to 90% in some setting. So the third one, A, is airway equipment. So different sizes that is appropriate for the patient should be available and checked. Airway equipment can range from a nasal pharyngeal airway, oral pharyngeal airway, the intubation equipment such as Laryngoscope, Endotracheal Tube, Stilet, and also if you cannot intubate patients, or before the intubation, you need to have a face mask and also the self-inflating manual resuscitator back valve mask. So this is a nasal airway. You can see you have different size here, and the name nasal pharyngeal, so it intends only to insert it in the nasal and then down to the pharyngeal level. It do not intend to go down to below the vocal cord. And it can be used in some semi-conscious child, which you want to maintain the upper airway pattern, but the patient is too conscious to use the oral pharyngeal airway. So one precaution is that it may cause epistaxis during the insertion of it. And this is the oral pharyngeal airway. You insert from the mouth and then down to, again, the pharyngeal level. But it is only advised to use in unconscious patients. And also they have different size over here. So this is the laryngoscope. And this is the laryngoscope where they have the battery. And this is the blade. This is the curved blade. It is the straight blade with a different size. So before you use it, you need to assemble them and also check whether the battery is good enough and the lighting is good enough. So for endotracheal tubes, they also have different size, and for pediatrics, there's a formula used to select uncuffed endotracheal tube. That is the H over 4 plus 4. And you need to prepare a half size smaller, that is a 0.5 millimeter smaller, and a 0.5 millimeter larger than your calculated size, ready at the bedside for use in case the estimated size is not fit for that child. So there is also a micro-cuff pediatric endotracheal tube also available. That is the balloon over here. It is a cuff tube. And they have an advantage of improving tracheal sealing and also reduce the risk of mucosal injury with the microcuff. And the size of it should be the formula you need to estimate, but with a half size smaller. So let's say you calculate the size formula by the formula is 4 millimeter. Then if you choose a cuff tube, it will be 3.5 millimeter. However, these are all just reference. So this is the back valve mask. You can see they have different size. It's an adult bag, pediatric bag, neonatal bag, and also this is the different size of the face mask. Then you need to prepare the appropriate size for different children. And this is the laryngeal mask airway, and it is an emergency rescue device. It can be used in patients with spontaneous ventilation, and the ventilation can be provided with a positive pressure at a modest level up to around 20 centimeters water. So you can see again, this is the laryngeal mask airway with different size. and there are many different brands. If you cannot remember what size the LMA that the child should use, you can always look at the tubing here or the packaging. They should have clearly stated that the kilogram that the mask fit for that child. So after talking about this all equipment, you need to always go back to a checklist that before the procedure, you need to make sure that you have already prepared the appropriate equipment. So this checklist is to remind you whether you have brought the age or size appropriate ET tube, mask size already checked. How about the oral airway, self-inflating bag, suction, laryngoscopy, and also whether the IV is patent. So next, I will talk about monitoring. There are a lot of kind of monitoring needed during the sedation. First of all is general observation, which cannot be replaced by any of this machine. Is what you look at the child, you need to assess the depth of the sedation, and also whether the child is comfortable, not comfortable, cyanotic or not, etc. And there are also other devices that used to assess the cardiovascular status and also the respiratory status, such as the pulse oximetry, capnography, blood pressure, ECG monitoring, and others if that patient needs more monitoring. So you can see this patient is cyanotic. So even if the saturation monitor showed a normal result, you will be very doubtful about the result. So general observation can never replace by the monitoring equipment. So what we monitor is whether they have any signs of respiratory distress, like nasal flaring, grunting, wheezing, stridor, dyspnea, recession, use of the accessory muscles, and also the color. Whether the patient look pale, how is the perfusion, whether they are mottling or cyanosis. So this is a pulse oximetry of different kind. And it allows us to have a continuous monitoring for the SpO2 and the pulse rate. So this is the waveform, and also this is the pulse rate, and it should be used in all sedation procedure. So the pulse rate measured by the pulse oximetry will detect bradycardia or tachycardia. If there is very obvious arrhythmia, it can also be noted by the irregular pulse volume. So sometimes the signal can be very poor. So what are the possible causes? First of all, the perfusion is not good because of the temperature is low, hypothermia, or there may be some peripheral vasoconstriction, or due to some movement artifacts, whether the patient is struggling or shivering. Another monitor required is the blood pressure monitoring. During minimal and moderate sedation, the measurement of blood pressure may unintentionally wake up the child, causing excessive movement. But at least before and immediately after the procedure, the blood pressure should be measured. And also, if there's any sign of instability, the blood pressure should also be measured. And in deep sedation, the blood pressure should be measured regularly, every 5 minutes. So the blood pressure we monitor is by the oscillometric method that you all should know. And it's also available with different cuff size, range from adult to a small infant. And the blood pressure is falsely elevated if the cuff is too small. It will be very low if the cuff is too large for the patient. So this is the way to choose the appropriate cuff. The cuff should cover at least 2/3 of the upper arm. and the bladder should encircle 90% to 100% of the circumference of the arm. So how we define hypotension? It can be also be done by this formula. This formula shows that the systolic blood pressure is less than 5th centile of normal for age. So let's say if the patient is 2-year-old, we will use this formula to estimate. Then it is around 74 millimmercury. So if the systolic blood pressure is less than 74 millimmercury, then the blood pressure is already less than 5th centile of the normal for the patient's age. So mild hypotension sometimes do occur during sedation because of the drug effect. As long as other parameters are stable, like heart rate, SpO2, respiratory rate, the perfusion capillary time, and also end-tidal CO2 are stable, then mild hypotension may be acceptable. But you need to closely observe and need to reassess the patient. And sometimes when the hypotension becomes more severe, you may consider treatment like fluid administration or reducing the depth of sedation. If the hypotension is severe that all the vitals like the heart rate, SpO2, capillary time has also changed, then it may represent a low cardiac output state, which is possible that there may be impending cardiac arrest. So you need to treat this condition urgently. You need to stop the sedation immediately, give fluid boluses, may need to have a vasoactive drug like dopamine or adrenaline infusion, and may require atropine. So on the other end, hypertension can also occur. It is mostly due to some excessive painful stimulus, or the sedation or analgesia is not adequate. Then at that time you need to consider additional sedative drugs, or due to the drug itself, such as ketamine. The next device we need to have is Ecg monitoring. So it monitors cardiac electrical activity. So it is important to note that the presence of electrical activity may not equal to the presence of peripheral pulse. If you have attended pulse, you should know that there's a condition called PEA, pulseless electrical activity. So in a stable patient, ECG may not be needed because the pulse oximetry, which should be put on everyone with sedation, can be used as a surrogate for monitoring of the heart rate. But if the patient is unstable, you're strongly suspicious of arrhythmia because the pulse oximetry shows some irregular pulse volume, or the patient has underlying cardiovascular disease, or the patient is in deep sedation, then continuous ECG monitoring should be used. The acceptable heart rates are important to maintain cardiac output, especially in young infants. And any non-sinus rhythm needs to be diagnosed, assessed, and treated if necessary. So when you monitor the ECG, you may note that the heart rate is too slow. That is bradycardia, sinus bradycardia. Then what are the causes? It can be due to decrease in the CNS sympathetic outflow from the sedation effect, or you are stimulating a vagal reflex that causing a sinus bradycardia, or the patient is hypoxic. So how about the fast heart rate sinus tachycardia? Most commonly is due to painful stimuli, or the sedation and analgesia is not adequate, or it is a drug effect that's caused by the sedation, like ketamine. So the next monitor is respiratory rate. Actually, many ECG monitor can measure the respiratory rate by the transthoracic impedance. because the lung inflate and deflate during respiration, and it will cause a variation in the density of the thoracic cavity, and it can be detected as a change in the impedance. However, this technique is prone to false negative or false positive signal. So capnography is the preferred monitoring technique for effective ventilation during sedation. So what is capnography? I will talk about it in later slide. And it is actually allow a real-time display of the ventilatory waveform, and also allow a breath-by-breath measurement of the end-tidal carbon dioxide. And it can be connected to different devices in a non-intubated patient. Like this. This is one kind of the portable capnography machine. This is showing the end-tidal CO2 reading, which is in millimeter mercury. This is the respiratory rate, and this is the capnography, that diagram you get. And if the patient is on nasal cannula, it can be connected to this sampling line of the capnography. If the patient is on a simple face mask, it can be connected also to the sampling line like this. So how to interpret this capnography waveform? So you can note that this is a breath, this is a breath, this is a breath. So this is the expiration, inspiration, expiration. So the peak here corresponds to the expiration. The trough is the inspiration. And the arrows indicate the highest concentration of carbon dioxide at the end of the expiration. So these are the few waveforms that different from the normal waveform that you may encounter in some sedated and non-intubated patients, and sampling the carbon dioxide through the face mask. You may see that from first graph, there is an increasing proportion of the entrained air with little or no carbon dioxide. This line here is getting lower, so it represents that the patient is hypoventilating. The second graph here, you can see that initially this waveform looked like the normal waveform that I just showed you. And then with a few of this like hypoventilating breaths, and it drops down to a completely zero CO2 reading. So this graph showed that the sample here just contained the entrained ambient air with no CO2. So it represents that patient is having apnea. And the third graph showed that initially this looks like a normal good waveform, and then this peak getting lower and lower. This patient is having hypoventilation with shallow breath, very shallow, and suddenly you can see the peak goes up, is followed by a deep breath. So when the patient is stimulated, the patient take a deeper breath, so it is expiring more CO2. So the deep breath at the end is a more accurate indicator of the alveolar CO2 than these shallow breaths. So the capnography is a continuous monitoring, and also is a very sensitive monitor for any presence of hypoventilation, ineffective ventilation, apnea, airway obstruction, and it can also measure the respiratory rate accurately. And also it can alert the practitioner before the child develops any desaturation. So how is the recommendation for the use of capnography in pediatric patients? According to the latest practice recommendation, capnography is not routinely required for healthy children undergoing procedural sedation. And however, for the children with comorbidities, like those with syndromal diagnosis and congenital upper obstruction, such as the Pierre-Robin sequence, those may need to use capnography based on clinical judgment. And also in certain procedure, like GI endoscopy, capnography may also be considered. So the next part of monitoring is the consciousness. Actually, the depth of sedation can be easily assessed by sedation score. And it can provide early warning of the sedation that may go deeper than our intention. And it allows the practitioner to intervene it proactively instead of having to rescue the child from desaturation for airway obstruction or apnea. So the sedation score we use is the UMSS, the University of Michigan Sedation Scale, that is validated for children. We choose to use this sedation score because it is rapid to administer at bedside. It allows repeated observations, and also it readily separates patients into different sedation categories. So this is what the UMSS look like. So if the patient is awake and alert, you give a 0 score. So the patient is not sedated at all. So if, let's say, the patient is having a deep sleep, only arousable with significant physical stimulation, he will have a score of 3. If the patient is not arousable, it is 4. And then you have something in between here. So as you see that how you give the scoring is you need to try to stimulate the child and to see how easily the child is being waken up. So in order to check this sedation score regularly, you may actually defeat the purpose of sedation. And in some situations like an MRI, it may be also difficult to assess the sedation score for infants. So how about other monitoring that may be required? For example, if the child is becoming unstable or the procedure becoming longer than what you expect, you may need other monitoring device such as the HemoQ to look at the hemoglobin. If it's like an invasive procedure with expected or unexpected blood loss, the dextrosticks to look at the glucose level, and also to monitor the temperature to prevent any hypo or hyperthermia. So this is the checklist that can help you to ensure that you have all the correct equipment with you. So first of all, you need to decide whether the escort is done by healthcare staff, nurse or doctor, or all 3 of them. And the monitor that required, like SpO2, heart rate, respiratory rate monitor until discharge, or even need an Ecg monitor until discharge, whether the patient needs a continuous end-tidal monitoring, and also the isolation precaution that required. So for the monitoring, the vital signs, including the oxygen saturation, heart rate, they should be documented every 10 to 15 minutes in a time-based record during moderate sedation. And in deep sedation, you need more frequent monitoring, like every 5 minutes. So this is an example of this observation chart. You fill in your name of the assessor, signature, time, date, and then the time that the procedure started, or the time that you give the sedation, actually. The time you give the sedation, and also you record the heart rate, SpO2. This patient do not have an end-tidal CO2, and then etc. So to summarize, a continuous pulse oximeter is essential to allow a beat-to-beat monitoring of the oxygen saturation and the pulse rate. And the capnography is highly useful to allow a breath-by-breath monitoring of the ventilation. And if it is a deep sedation or with a patient has a significant underlying illness, the vital signs, including the blood pressure, should be monitored every 5 minutes. If it is a moderate sedation, then the vital signs, including blood pressure, should be monitored every 10 to 15 minutes. If this monitoring is not affecting the sedation of the child, and also if you suspect any instability of the vital signs. And continuous EEG is used if the patient is not stable during sedation, you suspect arrhythmia, you anticipate that the sedation will become deep, and the patient has underlying significant cardiovascular disease. So what kind of extra equipment that may be required for sedation? So there are some special equipment, such as defibrillator, equipment that you need to prepare for potential difficult intubation, like a child with Pierre-Robin syndrome, equipment that used for endoscopy, and also a patient with known obstructive sleep apnea that they may need a non-invasive ventilation machine, CPAP machine, etc. So this is the appendix that you can find in the practice recommendation that help you to go through all kinds of equipment that you may need and need to prepare. So the next session is personnel and training. So this session is about personnel and training. So from the recommendation in the latest practice recommendation that for minimal to moderate sedation with oral sedation, a trained healthcare personnel to escort and monitoring is good enough. And as the sedation level goes up, and also if the patient has increased in risk, such as they belong to ASA class 3 or 4, age less than 1 year old, born prematurely but still with a post-conceptual age less than 60-week old, they are considered to be increased risk, even they only need oral sedation with intended minimal to moderate sedation. So this patient group require a dedicated trained healthcare professional, could be nurse or doctor. If the patient need a high level of sedation, like moderate sedation, and by using some intravenous medication, then there should be 2 personnel present. One is the doctor that administers the sedation and monitoring. Another could be a doctor or nurse that assists the sedation and assists the monitoring. If it is more deeper sedation, like for bronchoscopy, we aim at a deep sedation level, then there should be again 2 personnel that's responsible for sedation. One is the doctor administering the sedation and also monitoring. Another is the doctor or nurse that assists the sedation. And the 3rd personnel present should be the one performing the procedure. So in case of deep sedation, the person performing bronchoscopy should not be the one also administering the sedation. You need to have a separate personnel to monitor this deep sedation. So if it is a prolonged and expected to be painful procedure like OGD, then it should be done by experienced doctor, may need some ICU support, etc.